So introduce our first speaker. This is Dr. Samuel Hahn. He is an assistant professor of clinical medicine at the Yale School of Medicine. He was born in Seoul, Korea, but he was raised near Chicago, where he never believed that the Cubs would win a World Series. It's really been almost 8 years now. He did all his training at MGH. Has been in New Haven since getting fellowship in 2000. He was in private practice for 9 years before he became director of cath lab at the hospital in 2009. After the Yale acquisition, he joined the faculty as site director for Sundaresan campus, and then moved into safety and performance improvement. And today he'll be giving us a talk on perioperative management of anticoagulants and antiplatelet agents. Topic very near and dear to our hearts here.
Thanks. Thanks a lot.
So I'm here on behalf of not only HPC, but also the care signature group, Steve Hahn and Vinaik, which is Steve, I try to convince Steve to give this off, but Steve away, but like people out somewhere, so I guess, yeah, I think it's a good perspective. And unfortunately,
I think these are out somewhere.
Yes, has to go back to slideshow. There you go.
Yeah, obviously, I'm confident with that mission values, that kind of disclosures. I was going to use my computer and do a live presentation with the care signature pathway, but unfortunately, after the hyperdrive upgrade, over a month now, they still have not restored my playground access for some reason, so I can't use it without using a location, and I thought that would be an appropriate, prohibit thing. So I'm going to basically just show you a few screenshots of the care signature pathway, and then talk more kind of general principles of anticoagulation and providing management. So we spent a lot of time on this care signature pathway, and we actually solicited input from all of the surgical specialties. Urology, it was actually a pretty lively discussion, and it probably took us well over 3 months to get all this together. And all of this kind of sum total knowledge lives in this pathway, and you can get to it in one of many ways. You can type in anticoagulant, you can type in preoperative, but ultimately you'll get to this anticoagulation management section, and then under that we've got currently these 4 bars. There's one bar that's missing still. I'm not sure why. I kind of checked the scheme on that. Antiplatelet management, but that should be almost ready. It is ready, as far as I know. I'm not sure why it's not yet. But in any event, we can run these. So this is the first one we received. It's obviously DOAC's the most common agent used. We made that first, and you just kind of go down this pathway, fairly straightforward. Yes, no. All of these hyperlinks are very useful if you want to refresh your memory on pharmacokinetics of all these different agents. And it's fairly straightforward. The warfarin management pathway is also similarly very similar. It basically takes a lot of the DOAC information and just makes it specifically warfarin. And then the bridging algorithm really just goes over which patients need to be bridged and what are recommended medical recommendations. And then the last slide is the 4th panel, which is general principles of antithrombotic management, and that's where the antiplatelet cascade side. So just briefly talking about general principles of anticoagulation management. Obviously, there's 3 things we think about when discussing this. So you have to look at obviously the hemorrhagic risk of the actual procedure. That's where we look to you all, right? You're doing the invasive procedure. The thrombotic risk, what's the risk of not continuing the anticoagulant, and then obviously the use. One little caveat with the hemorrhagic risk is not only you have to think about the actual surgical procedure itself, but anesthesia plays a part in it too. The prevalence of nerve blocks, deflexus blocks, neuroaxial anesthesia, spinal anesthesia, those are actually considered very high risk. So sometimes even though the surgical procedure itself may be low risk, the type of anesthesia use actually makes it high risk. So any sort of neuroaxial surgery or anesthesia, a deflexus or peripheral nerve block is considered actually a high risk procedure because any sort of significant bleeding in that space could result in significant neurologic consequences. Thrombotic risk, the highest risk populations are anybody with an event within 3 months. So that's either a recent ischemic stroke or, a clear TIA, not a, waste pass TIA, but, a definite TIA that sounds like it was a real event. A recent venous thromboembolic event, recent valve replacement, or a recent coronary stent. Mechanical heart valves in certain positions are also considered very high risk. We'll talk about that very briefly. And then obviously the type of anticoagulation you're talking about, whether it's an anticoagulant or an antithrombotic antiplatelet agent, whether it's a DOAC, warfarin, or antiplatelet agent. I'm going to leave parenteral agents off this topic because they're fairly rarely used. Most of them will be in inpatient basis, so we're going to kind of skip that for now. Just a couple things to always think about, kind of even more important than the actual use of the guidelines and pathways are to always remember that these are just recommendations, right? So your clinical judgment, the judgment of the attending physician performing the procedure and the attending physician who are helping manage the anticoagulation are obviously much more important. And the key thing really here is shared decision making and documentation. I also do some medical legal consulting on the side, and I can tell you that the worst cases are situations where surgeons and cardiologists get into by just following a protocol, right, and not documenting any conversation with the patient, not documenting any conversation with the consultant, and then a bad outcome. Right? So the classic thing is, a patient who goes for some sort of surgery, the routine office practice is to hold all drugs, all drugs. Patient had a stent, 6 months ago, and there's no documentation anywhere. The patient has catastrophic outcome. And then everyone's just kind of like, well, that's our policy. And then they go back and they talk to the cardiologist. The cardiologist says, well, I would never have told them to stop yet, but they asked her. So those are the worst situations. It's not that you can't ever aspirin. It's not that you can't ever stop the aspirin or stop any medication, but you need to document your thought process and why that is, and document that you had a conversation with the patient about it. So if everybody agrees that a surgery is very necessary for whatever reason, and it also is necessary that you have to stop the aspirin, and everyone understands the risk of doing it, you gotta do what you gotta do. And in those cases, you're protected by the fact that everyone is aware of the situation, everybody understands what the risks are, and on balance, the decision was made that the benefits of the surgery outweigh the risks. And in that case, you proceed, and if you have a bad outcome, at least everybody has talked about it, and it's all upfront, and there's really no issue at that point, right? It's a thoughtful decision, you took into consideration everything you possibly could, you made that decision. So that's really the most important part of this talk that I'm giving, especially for the residents and fellows that are going to be going on into practice. Your best defense is documentation of the situation before it actually happens. That's the thing that I stress to you the most. And obviously, the higher the risk procedure, the higher the risk of stopping it or the agent or whatever. That is actually the case where you actually want the best documentation. The two extremes are very easy. Obviously, minimal risk procedures, cataract surgery, tooth extraction. We typically don't recommend stopping anything, right? You just start a procedure. And then obviously the extreme risk procedures, neurosurgery, neuroaxial surgery, where you have to stop everything. Again, like document that you have to stop it, and the risks of bleeding are just so high that you've got a choice. But again, there's very little choice in terms of what to do in those situations. Everything else is a gray zone. And this is where we, where some of these pathways come up and where your consultants can help you out. We like to postpone any elective surgery for more than 3 months after a recent event, some of those events that I talked about. But in general, with the modern agents that we have now, the anticoagulation management has become relatively simple. DOACs, your Eliquis, your Xarelto, your Pradaxa, you can generally hold for 2 days before the surgery, and you hold it the day of the surgery, within 24 hours after the surgery. That pretty much will cover the vast majority of patients. There are some caveats to that in the pathway. If you want to take a look in the care signature pathway. Pradaxa is predominantly renally cleared. If someone's got very low renal function, you may want to adjust how long you hold it, but that's in general 2 days is pretty much all you need. And given the rapid off time and the rapid on time, there's no loading involved, there's no waiting 5 days for the IR to come back up. We rarely need to bridge patients. The only time that I can think of bridging a patient on someone on a DOAC would be somebody who needed surgery. They just recently had a DVT or PE, and you didn't really want to stop the anticoagulation. In those cases, we might bridge, we might put an IVC filter in, something like that. But in general, DOACs don't require treatment. Coumadin, for the most part, is similar to DOACs. We stop it unless you're at a very, very high risk of a thrombotic event. And we only bridge with heparin or enoxaparin for the high risk with patients. And who are those? Those are patients with prior history of thromboembolism, whether it's stroke or any other arterial embolism. Patients with mechanical valves in the mitral or the tricuspid positions, the AV valves, venous thromboembolism within the past 3 months, or if they've got a hypercoagulable state, because in general they've already had a prior thromboembolism. That's how their diagnosis is made. So those are the patients typically that we would bridge with warfarin. Otherwise, we just typically hold it for 3 to 5 days to an INR to do our comfortable with no procedures. Antiplatelet agents are probably the biggest question, and this is the thing that comes up most. I think certainly in my interactions with your department, it's a tricky question, and I think our experience, and this is where the Yale New Haven Health, the Yale New Haven Care System pathway probably differs a little bit from the society guidelines and the other kind of general guidelines out there, because we have seen too many events on patients off aspirin, and we'll talk about that in a little bit. So if you look at the official guidelines from the American College of Physicians, even the American College of Cardiology is a little bit more vague on it, but they basically say that you can stop your antiplatelet agents, all of them, after a certain number of years. A little bit vague how long, but after a certain number of years after the point extent, it's okay to come off of that. As an interventional cardiologist, and again, after discussing this within the section of cardiology at Yale Medicine, we don't like to stop ever after a point extent. Obviously, we understand that sometimes we have to, but in general, if you can avoid it, we would prefer that patients stay on it forever. Because we have seen, and it's certainly well documented in the literature, that there are cases of very late stent thrombosis after stopping aspirin. And there does seem to be a rebound effect, and your highest risk of thrombosis after stopping aspirin is within the first couple of weeks after stopping aspirin. So it's almost actually a different situation. If someone, patient was at a stent 10 years ago, lost the follow-up, they stopped their aspirin 4 or 5 years ago, they now need surgery, you have to put that patient back on aspirin before their surgery. If they saw me in preoperative consultation, I probably would say yes after discussing with the surgeon, because the aspirin risk is okay. But that patient risk he's kind of self-selected himself and saying he's a low risk patient, he's tolerated no antiplatelet therapy for very many years. There is, a signal where patients who stop their aspirin seem to have the rebound effect, and their highest incidence of stent thrombosis, very late stent thrombosis, if it's going to occur in the first couple of weeks after stopping aspirin. So the worst possible case, right, is to take someone who's been on aspirin for a couple of years, they need some sort of surgery, you stop their aspirin, and then you make them hypercoagulable after surgery. So I think there's a connection there between those two scenarios, where you're dealing with not only the risk of the rebound, but you're dealing with the risk of surgically induced hypercoagulable state. Now that's conjecture on my part. I have no antibody study to prove that, but obviously physiologically it makes sense. For peripheral stents, carotid stents, and bypass surgery, there's less risk of thrombotic complications after 3 months. So again, we like to wait 3 months afterward. But in general, those sorts of procedures are involving much larger vessels. Your risk of thrombosis is much lower. So if you talk to the vascular surgeons and you talk to the peripheral interventionalists, they have less of an issue with stopping surgery. It's necessary for surgery. The AVT receptor antagonists are talking about Plavix, Ticagrelor, clopidogrel, prasugrel. The recent randomized trial data suggests that it's okay to hold these agents after 3 months. Probably even okay to hold it after just 1 month. The first month is very kind of tricky, and I think anybody who's had a very recent stent who needs a surgical procedure and you want to stop these agents, that certainly warrants a conversation with your consultant to discuss the situation and kind of maximize or optimize the strategy as best you can. I'll be honest with you, there is no great strategy. It really again comes down to risk benefit. We'll basically say, well, if you could postpone surgery, try to postpone surgery. If you can't, you can't, and we do the best that we can. But certainly the highest risk after coronary stent procedure is going to be within the first month, where we recommend doing antiplatelet therapy. And after that, the risk needs to go down very quickly. And again, we're now comfortable, as I said, most of us will say it's fine to stop your Plavix after 3 months for sure. Even after a month, as long as you stay on the aspirin, to go ahead and put our procedure. Some special considerations, some things that you're going to be seeing a lot more of now based on some of the randomized trial data that we're now doing. You're going to be seeing a lot of monotherapy now with just a Plavix or Brilinta after a stent, or just even a DOAC. there's data now that suggests that patients who haven't had coronary stents after a relatively brief time of dual antiplatelet therapy, it's probably better for them to be on just an ADP receptor antagonist or just DOAC. Who qualifies for that is it's still kind of controversial. Every cardiologist kind of has their own threshold, but as a surgeon, you're going to be seeing this more and more frequently. What do you do with those patients, right? So obviously, they're coming to you either on just Brilinta or they're on just products or just Eliquis, and they have a coronary stent. We're okay still. The prior recommendations still apply, but most of us now have been recommending that those patients, if at all possible, we switch to aspirin for the week prior to give them something, basically. Again, there's no official guideline recommendation on this. It's still an evolving area, and I think unfortunately the practice is getting a little bit ahead of the data, and we don't really know what to do with these things. But that's kind of where we stand at this point. Another special indication, obviously, is patients with ongoing hemorrhage who still need their anticoagulation therapy, right? So obviously, this is a situation you're all very familiar with. Patients who need their DOAC or their Plavix because they've had a stent, but they've had some hemorrhagic cystitis, and they're 3 days in the hospital now with the really cold. What do you do with those patients? Again, that's a conversation I think that you have to individualize the individual patient and come up with the best regimen, whether it's again just coming off everything except aspirin, coming off everything to and just accepting the risk of the thrombosis. Again, that has to be designed on a case by case basis. One thing that people don't think about commonly, though, to keep in the back of your head, patients with recent cardioversion for atrial fibrillation the first month after that is considered a high risk period, and again, we like not to try to interrupt their anticoagulation during that time period. If at all possible, and if you do have to interrupt it, it's all possible, we recommend using intravenous hydrates in those situations. In order to help with some of this, because it is confusing, and I threw a lot of information at you, because I didn't want to waste too much time with this. I'm trying to convince our section to try to do something that I'm calling preemptive optimization, and help you guys out, and help everybody, help myself out. Is basically put in every progress note. And so if you see one of my patients, if I see in the office in the past year, you're going to see something like this in the chart. I put this in every single progress note, every single outpatient. I basically preemptively say, okay, this patient, I saw him today, he's fine. If he needed some sort of surgery for the next time I see him, if he doesn't have any events, go ahead, go ahead. You don't need to do anything. He's fine, right? So in general now, we become very minimalist with our preoperative testing and evaluation, that if someone's stable and they haven't had a change in their clinical syndrome, we don't necessarily recommend that they have to preoperative stress testing or that's a whole other discussion, but that's that. I also put in here a statement about anticoagulation management and make the recommendations up front again for every single patient, and say that it's okay to stop Plavix or Brilinta for 5 days. What you do with Coumadin if they're on Coumadin, and you can hold the aspirin if they don't have a kiss period for coronary stent. If you do have a coronary stent, this last sentence gets changed, and I say I would recommend continuing the aspirin unless the surgical procedure is such a high risk, and then I recommend a discussion about the risks and benefits of holding the third section is antibiotic prophylaxis. Still comes up, we don't recommend any antibiotic prophylaxis for coronary stents for any circumstance. If not a valve, I put the situation in there for a valve. But I'm hoping that as cardiologists, it's easy with that, right? The template, we put this note in every single patient. But we're going to try to make it easier for our consultants and our surgical colleagues that when patients do want to go surgery, then all you have to do is just look at our class note, in addition to having care pathway available. Not sure how much traction I'm going to get on this, but I think it is a useful thing. Hopefully we'll see more of this. So I did I thought it was after they give me 30 minutes, I thought I could do it in 25, 20, that's pretty good. So and I also want to take time for questions.
Well, I think that's just fantastic. I'll keep a closer eye, but I think it's great to have that in the notes, and I wonder if we should put like an expiration date. I don't know, at some point, like if Orca could live somewhere in Epic, right? So it could be.
That's an excellent question. I'll have to think about that, see if something like that is available. So again, I think the recommendation, the guidelines have changed pretty significantly in the past, and it also, I think it depends a little bit on where the cardiologist is coming from, so the whole concept of preoperative testing, right? If you look at the actual studies that have looked at that, it's hard to find any benefit from preoperative testing at all, under any circumstance. Much less somebody who's been, followed by a cardiologist and they're clinically stable. So that's why, as I said, most of my colleagues and my cardiology colleagues, especially ironically the invasive ones, the interventional ones, don't recommend, for ischemic heart disease, if they're stable, they're not symptomatic, have a reasonable functional status. And this goes again along with the American College of Physicians guidelines, they've got an exercise capacity of 4 max, which is not much, right? We talk walking up, we talk stairs. If they can do that, they don't recommend. Yeah. The anesthesia now is so good, your surgical techniques are so good that the physiologic stress on a body from, non-aortic surgery is so minimal that there's, someone with stable coronary disease, that the likelihood of you finding something to do something about it is very low. And the flip side of that is with the preoperative testing, right? These were studies out of the 1990s, 2000s. We know for a fact that if you do preoperative testing, we find, an abnormal stress test, we bring that patient to the cath lab, you scan them, their risk of a post-operative complication goes up tremendously, right? Because you put a stent in, now they're not doing that. In the old days, before drug-eluting stent, this was the most popular in the 1990s. I'm dating myself here, but we did this all the time. And what we found is that patients had huge heart attacks after surgery because they're hypercoagulable. You just put a stent in, you think that you benefited the patient, you've actually done them great harm. Because you've taken stable coronary disease, you've crushed the plaque, you've exposed all the plaque to circulation. It's granted you stented it, but that's still an unstable situation until that artery, endothelial analysis and heals. You're actually turning a stable situation into unstable.
Thank you for a great talk. This is it's always really helpful to review these. I think to your point about I think there are sort of two sides to it. One is you want to make sure you're doing a safe procedure and you're doing it the right way, and this information is really helpful. But the other side is the medical legal side, like you say. And I think for me at least, it feels like having them see a cardiologist and have the cardiologist write this note that I know what you're gonna, we all know we're all on the same page, but having you put that in at least defrays some of that medical legal risk. I guess from is that true? In your experience, is it protective for the whole team when a cardiologist sees a patient and there's an event? Have you seen that be true? And I guess the follow-up to that is, if that's not necessarily the case, then do you recommend for patients who are stable or where the algorithm is really clear for us to just,
Yeah, so it all gets back to, from a medical legal sense, it all gets back to this nebulous concept of standard of care, right? So what is the generally accepted standard of care? So to the extent that for DOACs, as I said, the standard of care is that you hold it for 2 days before the procedure, and you just go ahead and, bridging except in very, very rare circumstances necessary. I think you should feel comfortable just going ahead and doing that, right? So if someone hasn't had a recent procedure. Now, look, you get served about you personally, but everybody is obviously very specialized and very focused, and it's totally understandable that it's hard to get a sense for everything that's gone on with the patient, especially if you're dealing with a very focal specialized sort of thing. And I think in that case, it's reasonable to reach out to either the primary care physician or the cardiologist and say, hey, look, yes, exactly that. I want to do this on this patient. Can you just drop a quick, recommendation in the chart about what to do with that anticoagulation? I think that's perfectly reasonable. Again, it gets back to standard of care. So if you're following the standard of care, regardless of whether or not you have a cardiologist, bless that, I don't think it really matters.
Yeah.
The situation comes up where your office has some sort of procedure in place, it doesn't really follow kind of what's out there, and then something happens, and you don't have some documentation as to why you didn't follow the standard of care. That's when you're gonna get into trouble.
We often talk about stopping anticoagulation before surgery with the concern of bleeding from DOACs and clopidogrel as our higher concern. But I wonder if that's actually true, because pharmacodynamically, it seems like it would be better to keep them on that than on aspirin, because there's a quicker off if they had a bleeding problem, and there's also the so-called quote anecdote for the DOACs, but not for aspirin. Do we actually know that aspirin is a less bleeding risk than the other ones?
That's an excellent question. I would defer to you guys, because you cut the patient open on these agents and you know what the bleed like. I can tell you from, talking to my cardiac surgical colleagues, right, they hate operating on patients on an ADP receptor antagonists, right? They feel that the bleeding is much higher, just clinically, right? They cut it bleeds, it's hard to coagulate. I think aspirin, yes, it's a much, it does, pharmacokinetic half-life is longer, but it's also less potent, anticoagulant agent compared with clopidogrel. So I think you're balancing that. So, but you're absolutely right. I mean, even with aspirin, you can give a platelet injection. You can argue about, how functional platelets are, but that's the antidote for aspirin is to, just like in its form of Plavix, you give a massive platelet injection, someone's bleeding. We like not to do that. But you're right, I'm not aware of any randomized trials of surgical procedures on, ADP receptor antagonists, which is on aspirin, what are the but just anecdotally, the really kind of, vascular surgeries, the surgeons do tell me that they bleed much more on aspirin.
You're talking about 81 milligrams of aspirin? Yeah. Probably, yeah.
Either, I mean,
Because we routinely now do, open surgery and I don't think clinically I've seen a noticeable difference in patients on 81 if they have a good reason to be on it. That,
Absolutely, yeah. 81, I basically.
Sam, while you're doing this, and I was gonna ask the work fact question as well, with the difference between bleeding with dual antiplatelet therapy versus just down to aspirin. It gets with that, I think, and we have a patient now with bleeding after having had a cath said, and is on dual antiplatelet therapy, can't stop both right now. It's painful. And what you said kind of amplifies what our experiences. The statement for the department, I think, is that Sam and Steve have been really helpful in terms of kind of helping us kind of set this up. If you remember, we debated earlier in the year, what are the high-risk procedures to our department and so on. The thing that we have to do now is we have to take department communication because our nurses and so on, preoperative teaching, telling people to stop aspirin. So in the course of the next couple of weeks, I think Jamie Kamala, she's on this call, and I have to kind of start the process of kind of educating our patients towards the idea that we can't just reflexively say, no aspirin, no, you stop your aspirin, stop your right beforehand. And that's the danger for us. So, I'd ask everybody, we've been kind of waiting for Sam to give this talk, kind of get that home so that doctors should be on the same page. Now we've got to make sure our communication there. So of course, the next couple of weeks, everybody would just kind of be aware of that and think through what you're telling your patients. And try to institutionalize. That's the I ask everybody to pay attention to that. So,
Yeah, we're really pushing the use of the pathways, especially for nurses, because it's really designed for kind of very quick, yes, no sort of questions. They can get to an area, and we have actually in some of the tabs, there's actually scripts there for nurses to give information to patients, like, okay, it'll say, okay, what day is your surgery? It's on a Friday, then you should take your last dose of Eliquis on Tuesday night, and then don't take it again until after the surgery. So all that's there and able for them to actually copy and paste into some sort of communication with the patient of this. So Steve's group done a really nice job with this. It's the functionality is improving every year. As far as the integration between the pathways between Agilent and and Epic, right now it kind of lives as a separate kind of grafted module on top of Epic, but as time goes by, they're integrating more closely. So you should be able to, basically just click a button and then everything just gets imported from them, right? That's the ultimate goal. It's supposed to have a manual copy and paste it back and forth. We'd like to be able to, almost generate part of it from within the pathway, make it easier for people to use. And then, getting back to the comment over here about, operating on aspirin, I think, 20 years ago, most surgeons would say, absolutely, yeah, I gotta stop the aspirin, I'm not gonna operate on aspirin. I think that the culture is shifting slowly. I mean, there's still some surgeons and some, and rightfully so, some procedures where they are even hesitant to operate on aspirin, but I think, I've definitely noticed a change in my career where the comfort level with aspirin is rising. And again, we haven't done a randomized trial, and I'm not sure we're ever gonna do one of, stopping aspirin before these sort of things. And, again, I think that's where I have a problem with where our guidelines are, where the data is, they're just, I don't think the data is there for the guidelines to say what they're saying. So we don't, there's still some significant uncertainty. And I think that we, having seen some of the tragic events that happen, and every year, I would say probably across the health system, at least once a year, we've seen a catastrophe where someone stopped their aspirin and, something has happened. Most recent case, a patient who had a stent probably just over a year ago and was told to stop their Brilinta and their aspirin, and they had some, mild, some really kind of very benign ophthalmology. It wasn't a cataract, pretty close to a cataract, but we didn't need to stop anything, we stopped it, and they had massive I think rebound there was a big part of it, we had to stop their Brilinta first for a while, and then maybe stop their aspirin for not. It would have been different, but you still see this from time to time.
Well, I mean, a common, so I think there's fairly, it's not it's not level 1 evidence, but in surgical literature, there are a number of publications looking at outcomes, retrospective outcomes of patients undergoing partial nephrectomy. These surgeries we worry about showing that the incidence is pretty low of major bleed. Well, I've had a few instances where the patient gets told to stop the agents by the cardiologist, and then there's some back and forth where I say, well, is there a way to communicate that we have, I believe in our departmental guidelines that we want to speak on Jamie's behalf, but I think that we have a comment that that we should, that we should continue these agents whenever possible. I think that's somewhere in our quality.
That's an excellent point. That goes to the schism within my own group between the interventional group and the non-invasive group. Again, so if you look at the kind of official guidelines, American College of Physicians and things, they say, after 3 years, 2 year, whatever, you can stop all their agents. Again, I think we're messaging this as well to our own colleagues, our own non-invasive colleagues, to recommend it, because you're absolutely right. I've definitely seen that recommendation from some non-invasive colleagues. So we're working on that aspect.
And do you think there's also a way to, operationalize this where, and I hate to add more epic orders or something, but maybe in general for our clearance, I mean, I guess if we move to something like that, then we don't need that. But a way to communicate, I'll sometimes put in my note, okay to continue 81 aspirin or something like that, but.
Michael, I think you're hitting the spot, like what you were saying about, we went through those, remember we went through already those operations, and stratifying the TRP and ACNL were some of the ones that were excluded. We went through all that, and I think we all know it. I think the communication to the patient compartmentally is a little bit scattered, and we have different people giving instructions. I think there's slightly different, and that's what we now have to kind of homogenize. Of course, the next it's not saying about this.
Yeah, I mean, if you can, I encourage you in your own notes like that, like I'm trying to, preemptively document. If you want to put a smart phrase in there or something like that, and basically by having that in there, I have it pop up and it takes literally, half a second, right? But it forces me to stop and think, or even just that split second. Okay, am I sure that it's okay for this patient beyond aspirin or not, right? So you can have a default where you just click enter and it just goes on, but at least by having that stop pop up for you, it kind of makes you think about it. So having a templated note is sometimes dangerous, but sometimes also it can be helpful as long as you force an interaction as opposed to just putting in text, right? And that's kind of the worst scenario. Just drops in text and you don't have to approve it. You don't remember that it's in there. You need some sort of mechanism where it makes you stop and permanently check an option.
All right, so I'll be introducing our next speaker as we enter sub-ICSU. This is Vinaik, Sundaresan. He is fourth year Yale medical student, applying for urology. He has been with us for the last 3 weeks, got 1 week left. He's been an active and engaged member of the team and has been a quick study. He pursued his BS in biology at WashU in St. Louis, where he first was exposed to research studying the gut microbiome in the lab of Dr. Jeffrey Gordon. That's only his second best highlight of his WashU career. He's also fraternity brothers with my much taller and cooler younger brother. Following his clinical rotations here at Yale, he pursued a dedicated research year in urology funded by the NIH. Medical Student Research Fellowship under Dr. Wheatman's guidance. Outside of the clinic, he is an avid tennis player and Dallas sports fan, a character flaw we've overlooked. And a fun fact about Vinaik is that he actually, when he was 10, was in a fender bender with Dirk Nowitzki. So he will be, he was MVP of the NBA at the time. So he will be giving us a talk on prognostic factors and active surveillance for localized prostate cancer.
So I'm going to be talking about prognostic factors and active surveillance for localized prostate cancer. And I want to start with a hypothetical case study of a 70-year-old gentleman. He has a PSA of 6.1. He has a normal DRE, and on prostate biopsy, he has grade group 1 disease on 3 tumors. And I think it's interesting to think about how a patient like this might be managed in different eras of urologic care. So let's say this patient was presenting in the pre-PSA era. He had a normal DRE in office. He likely never would have been biopsied or detected. He likely never would have received treatment. And if he truly had grade group 1 disease, and our modern assumptions of the clinical indolence of grade group 1 disease are true, it's very possible he would have lived his entire natural life without prostate cancer, possibly trying. Now, in the post-PSA pre-surveillance era, this gentleman had an elevated PSA that likely would have prompted a biopsy, which would have shown at least some grade group 1 disease. And my understanding is that many of these patients did receive definitive treatment, either with radiation therapy or prostate. And now in the modern era in 2024, again, the patient had elevated PSA, received a biopsy. There is a number of adjunct risk assessment tests like prostate MRI and genomic testing that are becoming more and more common. But many of these patients are actually monitored on active surveillance. That is generally for management of low risk prostate cancer. So active surveillance is a period of close disease monitoring. The cornerstone of active surveillance include serial PSA testing, DREs, prostate biopsy, and some guidelines include discussion of prostate MRI, but the actual utilization of prostate MRI regularly in active surveillance is still a topic that's up in the air. But regardless, a number of clinical guidelines do recommend active surveillance for low-risk prostate cancer. Both the AUA and NCCN recommend active surveillance for low-risk and very low-risk prostate cancer. And I've included a couple of specific snippets from both the AUA and NCCN guidelines, talking a little bit about the utilization of testing. So in the AUA guidelines, they say PSA values obtained no more frequently than every 6 months. Symptom assessment with DRE every 1 to 2 years. In NCCN, they discuss PSA no more than every 6 months and DRE repeat biopsy and possibly repeat MRI no more than every 12 months. So I think one thing that's interesting about this is, while these guidelines do give guidance on the maximum frequency of testing, there really isn't a lot of clarity on the cadence of that testing, the timing of that testing. And that kind of trickles down into a lot of heterogeneity in the actual implementation of active surveillance, which is a theme I kind of noticed when doing some research on this. That contributes a little bit to the inconsistency of the implementation and then adherence of active surveillance. So I guess an important initial question is surveillance safe? An important publication recently was this publication on the PROTECT trial, 15-year outcomes in the New England Journal of Medicine 2023. This trial had over 1,600 patients with PSA detected clinically localized prostate cancer. They were randomized to prostatectomy, radiotherapy, or active monitoring. Monitoring here is bolded because this is in contrast to active surveillance. This is a PSA only monitoring strategy. It has no repeat imaging of biopsy with a relaxed PSA threshold for defining progression. And it can be thought of maybe as sort of an intermediate between watchful waiting and true active surveillance. So outcomes were reported at 10 to 15 years, and one big report was there was no significant difference in cancer-specific or metastasis-free survival. And this was a very important publication, but I think there are some key caveats that should frame the interpretation of the study. So first is, if you look at the distribution of risk among the patients in the trial, 77% of patients had very favorable grade group disease. Now, up front, patients had the choice of whether or not they wanted to be randomized or did not want to be randomized. And one could interpret this as patients with unfavorable risk disease, quite reasonably so, chosen not to be randomized. And the randomization process self-selected for patients who had favorable risk disease. Regardless of your interpretation, I think it's fair to say that this distribution of risk among this cohort is not necessarily representative of all localized prostate cancer. That is to say that 77% of all localized prostate cancer is not very favorable disease. Another important caveat to frame the integration of a study is the high rates of conversion from active monitoring to treatment. So 60% of patients ultimately receive definitive treatment after monitoring. And that's baked into the survival benefit of monitoring arm. But regardless of these caveats, I think that especially for favorable risk disease, this trial did do a lot to demonstrate that active monitoring can be a safe strategy for keeping an eye on patients and also self-selecting for the subset of patients who need to be escalated care. So it's also important to note that use of active surveillance for low risk prostate cancer is rising. This was a study of over 20,000 men with low risk prostate cancer nationwide in over 350 urology practices across the US. And if you see this as a stacked bar plot over time, and the light blue shows the use of active surveillance in low risk prostate cancer. And there's a very clear longitudinal trend from 2014 to 2021. So in 2014, 26.5% of patients were under active surveillance. And in 2021, that rose to 60% for low risk prostate cancer. And another thing kind of baking into the story of the heterogeneity of active surveillance is the study found significant inter-provider and regional variation in utilization of active surveillance. Another thing driving the increased use of active surveillance may be the kind of explosion of new risk assessment modalities, such as prostate MRI genomic testing. So this is another nationwide analysis of over 65,000 gentlemen with prostate cancer between 2012 and 2019, looking at change over time in use of observation, MRI, and genomic testing. And on the left, you can see a geographic heat map, and there's some kind of gestalt visual trends that you might see. On the top, the A subplot is observation between 2012 and 2014 as compared to 2017 and 2019. The B subplot is MRI, and the C subplot is genomic testing. And these visual kind of associations or at the patient level associations. So prostate MRI, receipt of prostate MRI was associated with increased odds of observation, and genomic testing was as well. So the use of active surveillance is rising, but how good is our adherence to implementation of active surveillance? Well, concerningly, this analysis of over 10,000 Medicare beneficiaries showed that over 5 years, nearly half did not receive a follow-up biopsy, and around 30%, only about 30% received an additional prostate MRI. And I think this is an important thing to frame the discussion of active surveillance, because as the number of patients over time going on active surveillance increases, the number of patients being lost to follow-up will also increase. The number of patients in this 50% who are not receiving prostate. So given these risks of under surveillance, it's really important to try to identify patients who are high risk of upgrade, who might be particularly close to surveillance. And I think there are 3 patient groups that are particularly important. There's those patients who are at genuine risk of grade or lesion evolution and upgrade. There's also those patients who might have been initially misclassified on diagnostic biopsy and who are inappropriately considered. And then there's those patients who, as was demonstrated in the last graph, are at high risk of loss of follow-up and might never be seen again in clinic. The 2024 EAU guidelines said that more than a third of patients are reclassified during follow-up, most of whom undergo curative treatment. So identifying these high-risk subsets is of a lot of interest given the increasing use of active surveillance. So how can patients be stratified on active surveillance and be identified as high or low risk of progression? Well, ideally, there could be a combination of clinical parameters that we routinely get for all patients, and with the flourishing of these new risk assessment tools, some integration of genomics, MRI, that can all be synthesized into risk stratification, identifying patients who are at high risk of progression or low risk. So what I'd like to do is go through these different categories of factors and discuss a little bit of the literature surrounding their associations with active surveillance progression. And I'll start with routine clinical parameters because these are things like patient factors such as age, BMI, PSA density. These are things that are inexpensive, that are generally gotten for all patients, and have a long history of utilization in urology. So when looking at these clinical factors, one really important study was the Canary prostate active surveillance. This was a multi-center cohort of 850 men with a validation for a cohort of 533. They were diagnosed with Gleason grade group 1 disease between 2003 and 2017, and they were managed with active surveillance. Just a little bit about the PASS cohort. These patients received PSA testing every 3 months and clinic visits every 6 months. They also received ultrasound guided biopsies 6, 12 months, and 24 months after diagnosis, and then every 2 years. So what this allowed is for a cohort with actually very stringent active surveillance protocols and adherence. And the primary outcome was disease reclassification to grade group 2 disease or higher. And what these researchers did was they created a model using routine clinical parameters that most patients have them. And they tried to predict time to upgrade or time to disease reclassification. This is one of the major tables from the paper. And I've highlighted in red clinical factors that were associated with increased risk of disease classification model. And in green, factors that were associated with decreased risk. So you can see that maximum percent prostate pores, time since diagnosis, increasing BMI, diagnostic PSA and PSA kinetics were associated with increased risk, while prostate size and prior negative biopsy post-diagnosis were associated with decreased risk. Now, looking at the model performance, what this model is able to do is take a cohort of patients and stratify them to risk bands. So you have the lowest 10% risk group. These are patients among all patients in the cohort who, according to the model, are at the lowest risk of progression. They're highlighted in orange. And then you have the highest risk 10%. Those are highlighted in light blue. And on the left and the right are the initial modeling cohort and the validation cohort. And you can see that the low risk group has low rates of reclassification, the number of patients on surveillance dropping off remains low. And the high risk cohort has higher rates of reclassification. And so this study actually was not to identify high risk patients, but the inverse was to identify low risk patients who might benefit from reduced intensity of surveillance, thereby saving time, money, and patient anxiety. But it is sort of a proof of concept with the idea of tailoring active surveillance to individualized risk based off of routine clinical parameters, not things like MRI, genomic testing, but things that almost all patients have and that are relatively inexpensive. Another important factor that has been shown to be associated with reclassification is PSA density. So this is a paper that showed that looked at 384 patients across multiple institutions on active surveillance with grade group 1 disease on fusion biopsies. So these patients also had MRI at baseline. And the primary outcome was reclassification to grade group 2 disease or higher on surveillance biopsy. And it was shown that PSA density greater than or equal to 0.2 in modeling was significantly associated with increased odds of reclassification. So in this bar plot, you can see the bar plots are bin by PIRAD score. Increasing PIRAD score showed increasing rates of reclassification, something that I'll get into more in a little bit. But the gray, which is the PSA density greater than 0.2, had significantly higher rates of reclassification compared to lower PSA densities. So, read the AUA guidelines, they do endorse the idea of tailoring active surveillance to clinical factors. But again, there's not really specific guidance on what that actually means. But the idea of it is endorsed on AUA. So that was routine clinical parameters. Next, I'm going to talk about genomic testing, something that is rapidly increasing in utilization across a number of specialties, especially in prostate cancer. So one of the most widely used genomic tests is the Decipher test. And I just want to talk about this study, which was a multi-institutional cohort of 241 men on active surveillance. They underwent genomic testing with Decipher, and they were binned into either high Decipher category or low or intermediate Decipher category. Primary outcome was time to conversion from surveillance to treatment. And as you can see, there's a clear separation of the trajectories of these patients. So high risk Decipher patients spent less time on active surveillance. You can see sort of a widening gap between 6 and 12 months on this graph based off of the trajectory according to the Decipher category. And high risk Decipher score was strongly associated with conversion from surveillance to treatment. Another commonly used genomic test, the genomic prostate score. This is a score from 0 to 100. And this was investigated in this analysis of 111 men diagnosed with group 1 disease, managed with active surveillance. Primary outcome was again reclassification to group 2 disease or conversion of active surveillance to treatment. And the layout of this study was that patients had an initial biopsy where they had a 17 gene GPS score that was dubbed GPS1. And then on follow-up biopsy, they had a repeat GPS score dubbed GPS2. And after adjusting to for some clinical parameters, the like PSA density, the percent positive biopsy boards, and the site of diagnostic biopsy, GPS1 was significantly associated with upgrade at second biopsy and conversion to treatment. Now, this is like somewhat promising and exciting information, but there are some real problems with the use of genomic testing in association with risk stratification for surveillance. And one of the big challenges is tumor heterogeneity. So genomic testing is based on a localized assessment of tissue, and there is topography in the genomics of these tumor regions. And I've seen this even myself just through chart review. Among individuals, there's significant variation in genomic testing, and it's sometimes hard to interpret. Let's say a patient has a high Decipher score on one genomic sampling and then gets downgraded to lower intermediate. How does one interpret that in a clinical context? So given this challenge and sort of the lack of really concrete evidence, the current AUA guidelines argue against the use of repeat genomic testing in active surveillance. Final thing I want to talk about is, to me, the most interesting, because this is what I've spent some of my research here focused on. It's the use of MRI in patients with active surveillance. So one of the fundamental assumptions of active surveillance is that we have an understanding of the true disease burden of prostate, and that the highest grade disease has been sampled. But the paradox with that is that that assumption is made off of prostate biopsy, which is a localized tissue sample and a localized risk assessment. So there's an inherent risk of misclassification and inappropriate utilization of surveillance. So an important question is, can prostate MRI, which is a full gland assessment of disease, provide complementary information to prostate biopsy and inform active surveillance candidates at risk? So Dr. Leitman and I looked at this from the Yale New Haven experience, and we asked the question, what is the natural course of patients on active surveillance with grade group 1 disease who had a PIRADS5 lesion? So these patients are in a bucket that you could call imaging biopsy discordance. They have very low risk findings on biopsy, but high risk findings on MRI. And our cohort included all YNHH patients diagnosed between October of 2013 to December of 2022 with GG1 disease on initial biopsy and greater than 1 PIRADS5 lesion on MRI. Now, I think an intuitive first question is, how common is this discordance, right? Are these like complete zebras that are 1 in a million that you're never really going to see in clinical practice? But interestingly, this was surprising to me at least, if you look at patients with PIRADS5 lesions and the biopsy findings of them, over 20% of these patients have grade group 1 disease or benign disease on initial biopsy. So this is not just some complete random subset of patients. This is a Sankey diagram of what we found. So we had 110 patients with grade group 1 disease and PIRADS5 lesions. 6 received upfront treatment, but well over 95% were started on active surveillance. And consistent with that evidence I was showing earlier of the low rates of adherence to active surveillance, even at an academic center like Yale with defined active surveillance protocols, only 61 patients out of that 104 cohort received a follow-up biopsy. 43 patients received no follow-up biopsy. If you look at the patients who did receive a follow-up biopsy, over 70% were upgraded on active surveillance, and of those upgraded, the majority were upgraded on first active surveillance biopsy. This is a Kaplan-Meier curve of the same data. So 70% of patients were upgraded, with most upgraded on first surveillance biopsy. And of those upgraded on active surveillance, nearly 1/3 were upgraded to greater than Gleason grade group 3 disease. In multivariable regression, when we adjusted for clinical parameters, imaging parameters, only Decipher score, which was modeled per 0.1 unit increase, was associated with odds of upgrading. And that's kind of giving some insight into the potential synergy between some of these prognostic factors. And then it's really interesting when you look at patients who were treated. So there were 47 patients in the cohort who ended up being treated. And 15 of those patients had subsequent tissue sampling in the form of prostatectomy and surgical pathology. 93.3% of those patients had Gleason grade group 2 disease or higher on surgical pathology. So taken together, you could make the argument that PIRAD's 5 findings in the setting of Gleason grade group 1 disease could suggest initial misclassification. Now, it's possible that these patients had genuine lesion progression, that their disease evolved over time. But the fact that most of them were upgraded on first surveillance biopsy suggests that potentially the time window for that evolution to occur didn't happen, and that they were just initially misclassified. It also suggests a potential role for confirmatory testing, such as like a confirmatory biopsy or genomic testing that was associated with upgrading our modeling. Now, there's also much more significant, robust studies that have examined prostate MRI. One is the ASSIST trial. This was a prospective randomized multi-center trial for women with grade group 1 cancer who were eligible for active surveillance. This is a schematic of the study design. There were 259 patients on active surveillance. They were randomized to either systemic confirmatory biopsy or MRI plus targeted systemic biopsy. And the outcome was active surveillance failure. And this kind of gets at the fact that although MRI can provide independent prognostic information, it can also refine the existing gold standard for risk assessment, which is prostate biopsy. The initial results of this trial showed no difference in the rates of upgrade between MRI and non-MRI guided biopsies. But in an important 2-year update follow-up, it was shown that upgrading rate was 50% lower on the MRI group versus the systemic biopsy, and that there were fewer active surveillance failures in the MRI compared to the non. So this evidence taken together is supported by AUA guidelines say that in patients selecting active surveillance, clinicians should utilize multi-parametric MRI findings to augment risk stratification. But importantly, this should not replace the existing gold standard to periodic surveillance biopsy. It also goes on to say that serial MRI testing and the evidence supporting serial MRI testing is still under. So I just want to end with another case. This is an actual case. This is a case that I got described into during my first week of my sub. And this was a 68-year-old gentleman who underwent diagnostic biopsy in April 2022 due to elevated PSA, PSA 5.2 and density 0.16. His biopsy showed grade group 1 disease, 3 of 13 quarters. His pre-biopsy MRI showed a PIRADS 5 lesion. Decipher testing showed intermediate risk when you started on active surveillance. He had a surveillance biopsy in February 2024, which times PSA increased to 9.4 and density of 0.28. And just looking at some of the prognostic factors that I was talking about, he had PIRADS 5 lesion, he had intermediate risk Decipher testing, his PSA kinetics and PSA density. And his surveillance biopsy showed grade group 3 disease in 2 of 18 quarters. He was converted to active treatment, received radical prostatectomy, and pathology showed group 4 disease with peritoneal invasion but negative surgery. And I thought that kind of after my year of research looking at patients with Gleason 6 PIRADS 5 lesions, kind of nicely tied together the translation of that abstract research into actual clinical practice. So conclusions: active surveillance for lowers prostate cancer rising, but implementation and adherence remains poor. Routine clinical and patient factors that are inexpensive and widely available can be used to tailor active surveillance and jaundice risk, but there's a lack of concrete guidance on what that would actually mean. And there's no clear evidence for genomic testing, but higher risk features on prostate and prime can be considered an adverse response factor for kind of. So thank you.